Thank you everyone for joining. I'm going to kick us off with our MRA president, Allison Sheets, and give Allison the opportunity to say a few words before we jump into our presentation. Allison?
Thanks, Carrie, and thanks everybody for showing up for our third Thursday, and thanks to Brian for the topic. It's timely as things are getting cold, so we're getting close to Christmas time. Happy holidays to all of you guys. I want to apologize that I don't come to all of these to talk to you guys, but given my work and travel, etc., I can't make every third Thursday, but I make the ones I can. And I'm just going to take a couple minutes today. I want to talk about our upcoming winter business meeting. I'm super excited about it because it's the first one that we're going to have in person since February of 2020. And unlike the spring conference, the winter business meeting is really a working meeting. We don't have all the educational opportunities that we do in our spring conference. But our Saturday, especially the day before our actual business meeting, we have a lot of opportunity to work together, talk about new ideas and things that we're doing and things that we have done. And so I'm thinking about a variety of ways to make it fun, interesting, not too dry for a Saturday of sitting inside in Salt Lake City. I would encourage you guys, if you haven't booked your tickets or booked your registration, to do so. Kaylee Bell should have sent you an invitation to register on the 6th of January. So if you haven't gotten that in your inbox, take another look. And if for any reason you have any questions, can't find what you need, you can always reach me directly at president@mra.org. But once you register, consider coming in on Thursday night, or coming in for Friday, because we're going to try to have a couple events available for people on Friday afternoon, things like maybe going to a climbing gym or getting a tour at the Utah Avalanche Information Center. A lot of people get together and go skiing, both at the areas and the backcountry. The skiing around Salt Lake City, if you don't know already, is usually fantastic that time of year. So come down for Friday events. We'll have a hospitality suite Friday evening at the hotel. We'll have a hospitality suite Saturday as well at the hotel. There will be food provided, all except for Saturday's dinner. Some other things I want you to think about: if you've got any particular issues that you want addressed in the agenda, let me know. We'll get them on the agenda or talk about them on Saturday. I really want to get people's input on where you want to see the MRA going. And we're going to do our best to show you what we've been up to the last couple of years and where we think as leadership we should be putting our time and energy. So I look forward to seeing a lot of you there. Please register before 31st of January. It's cheaper if you do it that way. And I think that is pretty much everything that I wanted to say. The other last bit of information I wanted to pass off to you: I've gotten a lot of inquiries from folks about the recording of these third Thursdays. Just a reminder that they are all recorded. The ones that we do every quarter that are mission reviews are not recorded. And we have been a little bit remiss in getting that link onto the MRA webpage, but there is a MRA YouTube channel. It's youtube.com, and then it's Mountain Rescue Association 4599, and that's where all these YouTubes go, and they're up to date as of last month. So if you miss one and you want to catch up on it, there is a way to get that access to that. It's really open to the public, other than the mission reviews, which are not recorded for privacy concerns. So with that, I am done, and I'll pass it back to you, Carrie, and you can introduce Brian. And you guys enjoy the talk about hypothermia, and go get a jacket, because I saw a couple of the videos, and you're going to get cold watching this presentation.
Great. Thank you, Allison. Thank you all for joining. I'd like to introduce Dr. Brian Feinstein, originally from upstate New York. Brian made the pilgrimage out west after finishing up his undergraduate degree. And 2 weeks after graduation, Brian almost died of HAPE, trying to climb Denali, and realized that he might benefit from some medical training. He ended up taking a wilderness EMT course and subsequently fell in love with medicine. He is currently an EMS fellow at Washington University in St. Louis, and having completed a residency in emergency medicine at Maricopa Medical Center in Phoenix, Arizona. Brian spent the interim working various jobs, from ski lift operator to mountain bike guide to flight paramedic, and living between Arizona, Utah, and Wyoming. Brian has extensive experience in search and rescue and critical care transport. He has worked for the National Park Service in Grand Canyon and Denali National Parks and volunteered for Seattle Mountain Rescue. Brian states he is most at home sleeping outside and or living out of his truck. So with that being said, please welcome Dr. Brian Feinstein.
Thanks, Carrie. I
Yeah.
appreciate it. And thanks, Allison and Charlie, for inviting me. I gave a similar talk to the Seattle Mountain Rescue probably about a month and a half ago. And apparently it wasn't horrible enough that they didn't ask me to come back. So we'll see how this goes, but appreciate you guys having me. Let's get this. Can you guys see this?
We got it.
All right. So obviously there's a lot of people on this call that have a lot of experience as well. So if anyone hears me saying anything incorrect, dumb, or has any anecdotal experiences they want to inject, feel free to speak up. I'd like to hear other people's experiences. So with that being said, so yeah, my name is Brian. This photo right here is probably the closest I think I ever came to dying of hypothermia. This is up in, if anyone has ever been up in the Ghost region in outside of Calgary. This was the ice climb on the Sorcerer. And just after this photo was taken, a bunch of spindrift. I had a video, but I couldn't find it, unfortunately, but there was probably the worst spindrift I've ever been in my life. And definitely thought I was going to freeze to death hanging at a hanging belay on this ice climb. So it was super fun though. So I would probably do it again. So I have no disclosures at this talk. If anyone knows how to make money out of any of this stuff, I'm open to suggestions, but I currently have no disclosures. So just quick background. I was after almost, I basically pretty much died or came close to dying in Denali and got rescued by the National Park Service, and then took a wilderness EMT course. My first job was a EMT in Jackson Hole Fire, and that's where I kind of got my start. I went to paramedic school and then came back there and worked as a paramedic. After that, I have had a few different hats, but these are the ones I'm kind of most proud of. I started working for Grand Canyon National Park, worked for Classic Air Medical, which is a private kind of air medical rescue company in the Intermountain West. Now part of Intermountain Healthcare, but they do a lot of wilderness rescue in Utah, Arizona, and Wyoming. I went to medical school in Seattle, so I got involved with Seattle Mountain Rescue. Unfortunately, I wasn't able to be operational during medical school because I was going through a couple of surgeries on my hips, but met some of my best friends in Seattle and got involved with their medical committee and worked to kind of establish some standing protocols and just kind of revamp a lot of the medical training and guidelines with Seattle Mountain Rescue with good friends of mine, Anna Condino and Miles and Gabe. And then went to residency in Phoenix at Maricopa Medical Center. Currently, I am working in St. Louis as a EMS fellow with Washington University. This was a photo from a couple days ago. So this is one of the fire departments I get to work with, Melville. So it's slightly different than working in the mountains. But it's super fun, really high level medicine being performed. It's pretty cold right now. It's like 32 and started to snow. So I assume we probably will see some hypothermia here in the next couple days or weeks or months. But this is what I'm currently doing for from July to July of this year. As you can see, there's not much representation in St. Louis for the Mountain Rescue Association. So if anyone wants to open a chapter, I think there's probably some room in the middle of the states here. But I thought that was kind of interesting. And there's obviously a lot of places here that I'm not sure who's on the talk, but there are some places here, obviously, that, up in the Pacific Northwest, obviously north here in Calgary, the Intermountain region, and up northeast they're going to see a lot of hypothermia. Not sure so much down here in the Panhandle, but it's possible. And I know there's a lot of people on this call. If anyone wants to, I'd like to know who's kind of in the audience. So if you can put in the chat, feel free to put in the chat like what kind of level medical training you are. I would love to see that, just so we have kind of a good representation of who's on the call. Cool. Yeah, and keep doing that. So it looks like it's a lot of EMTs and wilderness first responders, which is great. It's kind of what this talk is geared to. So this is from the Wilderness Medicine Society guidelines. This is, they put out consensus guidelines occasionally for, wilderness medicine. This is the hypothermia paper. I think this is a really good, concise document about kind of infogram about hypothermia and the treatments. So we're kind of going to go through some of this stuff, and we'll come back to this in a few more slides. So kind of basic physics, how does one become hypothermic? And essentially it's an energy equation. When you lose more heat than you are gaining when you're out in the elements. And then there's various physics that essentially cause you to lose heat. So convection is moving air, radiation is just straight loss of heat through just electromagnetic energy. Evaporation is convection and evaporation are super very powerful mechanisms to remove heat. I did residency in Phoenix where we didn't see a lot of hypothermia. We actually saw a lot of heat stroke. And these are the two of the tools that we'd use, as well as conduction to cool people as fast as we possibly could. The thing that we kind of forget too is respiration causes a lot of heat loss. So people that are breathing fast, potentially sick, have other things going on, can cause a lot of heat loss as well. And then obviously the prevention is addressing all these potential losses of heat. The treatment is going to be reversing them and then adding potentially exogenous heat that we can do to add some fuel to the fire. And it seems like there's a lot of people that came through the chat that show that they're wilderness EMTs. So I would assume that a lot of people have done scenarios. If you went to a wilderness EMT course, I remember I did my first one in 2005 up in Leavenworth, Washington. And it was in the fall, and we did outdoor scenarios. And if anyone's done that, I would assume everyone's kind of experienced that, where if you're being the patient in one of those scenarios and you lay on the ground, even getting the scenario ready, and it's maybe not be a hypothermia scenario, but if the weather is fairly cool, it could be even in the 40s and 50s, but you lay on the ground for 10-15 minutes for the scenario, and then 20 minutes for the scenario, and you can actually get really hypothermic and start actually having these physiologic responses of shivering and shaking very quickly. And it's something to keep in mind, because in Seattle, a lot of the Pacific Northwest areas, as well as pretty much anywhere where you have, anywhere that has low temperature, but I would just add that in the Pacific Northwest, or areas that are going to be very humid. The Northeast can have this as well. That evaporation and convection can be kind of even exacerbated. And most of these patients that might even just have like a broken ankle, or something that keeps them immobile, not even critically ill patients, are going to be hypothermic by the time we actually get there on scene, especially if the weather's bad and you're not able to to mobilize like air resources and things like that can get there quickly. So some of these patients can be profoundly hypothermic before we even show up on scene. So a lot of this prevention doesn't happen, but the treatment is things that we can show up on scene and intervene and prevent them from getting worse. So the big things that happen with hypothermia, This is the biggest thing that we worry about is the cardiac effects of hypothermia. So you get basically the heart does not like being cold. When it gets below 90 degrees, it becomes very irritable. You can go into arrhythmias, essentially, which are abnormal heart rhythms, and the most dangerous being ventricular fibrillation and asystole, which tend to happen the lower you get. These are lethal heart rhythms. Obviously, neurologic, people tend to get kind of impaired. You always hear that people tend to get confused, take off their clothes, things like that. Judgment becomes impaired, and then it progresses down the pathway to coma, stupor, and death. The nice thing about this neurologic response, though, is that this provides us with potentially a time window where we can actually resuscitate some of these patients, because it essentially decreases cellular function, it decreases glucose, glucose need in the brain. So we get a lot of negative effects from the neurologic aspect. However, the benefit is that this is what provides us with potentially salvaging some of these patients neurologically intact. The thing I always remember from my wilderness medicine EMT course was the hypothermia, any kind of ultrametal status. You get the dickhead syndrome, which is it's like your buddy that has drank too much, or just somebody that's just not a great person. They tend to get irritable, angry, and can just be confused. So pulmonary, this can result in basically just like shallow respirations, weak respiratory muscles, which can lead to increase in your carbon dioxide retention and a respiratory acidosis, which, as we'll talk about in a few slides, basically makes everything worse. And then obviously renal. So these are the kidneys. So you tend to get, we see this a lot with post-cardiac arrest patients that get cooled in the hospital. When you get cooled really quickly and to a certain level, the kidneys don't like that. And they tend to it's kind of a cold mechanism. I'm not really sure why that happens, but you tend to dump a lot of urine. So the kidneys just stop retaining basically fluid, and your urine output goes up incredibly high, which can be very detrimental if you're already dehydrated or have other things going on, like subsequent traumatic injuries. And then heme is kind of blood. So you basically get coagulopathy. So the clotting enzymes that we have and the clotting factors that we have in our blood that help us, help our blood clot, tend to not work, and this can result in coagulopathy and DEC, which is disseminated intravascular coagulopathy, which it usually eventually leads to death. So the big take home from this point, from this slide, is the fact that if we have healthy patients that maybe just have a, like I said, like an ankle injury or something, that are immobile and become very hypothermic because they don't have the appropriate gear to wait 2 to 3 hours for somebody to come on scene to be able to help carry them out. All this stuff can happen to them. And then you think about patients that, may have been skiing or, ice climbing or whatever, and were in an avalanche, or, fell 40 feet ice climbing and now have pretty significant injuries. They're going to be at higher risk for all this stuff. So it's just something to keep in mind. And then this is kind of the last kind of sit. We'll talk about frostbite here after a few more slides. So predisposing factors. So extremes of age. We have a lot of, at least in Seattle, I know probably the Front Range has a similar population in terms of access, and a lot of older, I just turned 40, so I'm feeling like I'm hitting that kind of, I can say older patients. But there's, we still have, I know when I was in Jackson, we'd see 70-year-olds out on the, pretty frequently out on the boot pack on Mount Glory. And so this is something to keep in mind, because places that have easier access, like Seattle and the Front Range, that have a city but you can drive up into the mountains quickly, could have extremes of age. We're not going to see too many young people, but the skin is not as, basically older patients have multiple things like skin and cardiac abilities to compensate. So they're not going to be able to compensate as well. Let's see here. So high altitude. So this causes a lot of different issues, but the higher you go, the more you have respiratory issues. So you tend to breathe faster at high altitude, so you can become dehydrated. You can, there's more exposure, and that tends to lead to quicker and worse outcomes. Alcohol and drug use. We probably tend not to see this too much, but if you're working in an area near ski resorts, things like that, obviously that is not uncommon for people to be out skiing and drinking or doing drugs, and that can exacerbate the underlying issues. And then trauma victims. So this is the majority of, I feel like, of what we see in mountain rescue. There tends to be a small percentage of medical, people that have potentially, asthma or like cardiac issues. Obviously, there's the people that have that are just lost, but majority of the people that we're going to see are trauma victims, with the majority being mild to minor trauma that prevent them from ambulating out of the wilderness, or maybe they need pain control or additional help, up to obviously multi-systems trauma and critically ill patients. And this is kind of what we were talking about before, with how the hypothermia and trauma and kind of what we're going to see makes kind of everything worse. So this trauma, this is without being out in the wilderness. This is what we're taught in medicine, and then when we do trauma resuscitations, basically a trauma patient is prone to all of these things. So if you're ever in the hospital or in the ORs and trauma, they keep the ORs and the trauma base uncomfortably warm, because even in the hospital, having a small drop in your core body temp can basically cause a cascade of badness that can result in worse outcomes. We don't have the luxury of a trauma bay and nice warm heaters in the wilderness. So we are just trying to mitigate and prevent this from getting worse. But obviously, like hypothermia here results in coagulopathy, which results in acidosis, and all these things reinforce each other, and all these things make outcomes worse. So one of the things we can affect in the wilderness setting is stopping the hypothermia. We can't really affect a lot of this other stuff. Some systems can potentially have, if you have paramedic level or MD nurse, PA level in the field, there's potentially things that you can do to potentially reverse some of this stuff, like giving like things like TXA bad trauma can potentially reverse some coagulopathy. But one of the main things we can do, and it's a very inexpensive and very effective thing, is keeping these patients warm and preventing them from getting worse. And so this is I don't know if I know we went over this, but let me, okay, we're good to go. If anyone's ever seen this, this is a short little video I'll watch from, it was one of my favorite short films from the Banff Film Festival, maybe like 8 or 9 years ago. So we'll just play this. All right, so apparently alcohol may be protective in some circumstances, but probably only in Norway and Sweden, is what the take home from that video. Don't recommend that, but you never know. And then I was just looking at the chat. Richard Yoakum put in, cold-induced central shunting of blood causes increased GFR, which is glomerular filtration rate, leads to more urine output, which makes sense. I probably learned that and had that in my brain at some point, but it was not in my brain currently. So thank you, Richard, for pointing that out. And Matthew Franken says vodka explains a lot, which I think that's self-explanatory. So treatment of mild to moderate hypothermia. This is mainly what we're going to see in the field. So this is where patients are going to be usually awake, responsive, usually able to follow directions. But it's a varying range. So they can be on the mild end, or they could be on the moderate end. So mild hypothermia is usually around 35 Celsius to 38 Celsius, which is 95 degrees Fahrenheit up to 98.6 degrees Fahrenheit. And then we basically classify moderate hypothermia as 32 degrees to 35 degrees Celsius, which is just under 90 degrees Fahrenheit to 95. So if you've never been to moderate hypothermia, I feel like I might have been there once or twice, but it's pretty miserable if your core temp is actually in the low 90s. So obviously easy things that we can do if they're awake and able to follow directions and eat is to feed them. We want to feed them warm fluids. We want to feed them things that are going to create energy, they're going to be able to use that energy to create heat. If you can get them to exercise, like doing sit-ups, jumping jacks, push-ups, things like that, whatever somebody's able to do, if it's depending on their mental status and injuries, can be helpful to prevent things from getting worse, and that's actually able to help improve their improve potentially their temperature. And obviously keeping people engaged when you're in a bad situation, mentally engaged, can be very profoundly helpful to try to keep things in perspective and keep their mind off the big picture. And then obviously stabilize injuries and stop bleeding is going to be a huge thing for that. So moderate hypothermia tends to be where people stop potentially being able to follow commands. They might not be able to exercise. They may not be mobile. And this is where you're going to start seeing their mental status potentially decreasing. And that you just have to be very cognizant of this, because this is where I feel like we can do the most good to turn people around. The mild hypothermic people that are able to get to early and able to get their potentially wet, or if you're in the Pacific Northwest or somewhere with rain, getting off their wet clothing can be and then giving them something warm can be very helpful. But the moderate hypothermic patients are going to be the ones that are not going to really be able to help themselves and help you treat them. So you're going to have to do a lot more for them, but we can prevent these people from becoming worse. So this is where you're going to start thinking about active rewarming, having things like jet boils or whatever you want to have in your first response pack to be able to heat up snow, heat up water, to be able to use hot water bottles, things like heated blankets, obviously another person, and then using the hypo wrap, which I feel like is a very core concept in mountain rescue, which we'll kind of go over here in a little bit. And then if you have the ability, warm IV fluids in the wilderness setting is very difficult to do unless you're coming or potentially having a helicopter rescue or helicopter rescue team coming in. But there are some devices, I'm not sure if anyone is actually utilizing them, that can potentially warm IV fluids in the field prior to actually going into the body. So then we're going to talk about severe hypothermia. So I think everyone's heard the phrase, you're not dead until you're warm and dead, unless you're really dead. So kind of the first thing you have to decide is, obviously, is it really worth it? Is there a pulse? Are they breathing? Are they completely frozen? Do they look like they've been out for days? And we'll talk about avalanche here in a little bit, but the other big thing that you got to keep in mind is, do you have the resources to care for them? So if you're one or two people on a hasty team that get in first on scene, and you get to somebody that's profoundly hypothermic, maybe has a pulse, maybe isn't, do you have the resources to do CPR in them, or intermittent CPR, like we'll talk about a little bit, or, be able to get them out? And is that something that we have the resources to do to keep yourself safe as well as treat the patient? So just something to keep in mind. This depends a lot on the resources you have in your region. And we'll kind of get into that in a little bit. So if you're going to treat, obviously air evacuation on these profoundly hypothermic patients is ideal. Obviously, that's not always the case. It may end in a ground carryout. And then we'll talk about some of this stuff in a little bit below. But like I said, a lot of this stuff depends on where you practice and what resources you have. So like in the Seattle area, we have several air resources. Like we have King County Sheriff's Office, which provides a paramedic level air evac that has short haul capabilities. And then we have the Snohomish County Helicopter Rescue Team, which provides a hoist capability. And then they are not always available, or the weather may be bad. And we also have the Whidbey Island Naval Air Station, which can provide some resources. And if you have those resources, potentially caring for these patients, even if you don't have the initial resources to do it, as we'll talk about in a couple case studies here in the end, can be beneficial. But if you don't have these air evac resources, some of these patients would be very arduous. And we're talking about the critically ill patients here that are potentially salvageable, but it's just something to keep in mind and something to discuss with your unit as to what options you have to get them out. So a couple things that we'll talk about here, and these things. So after drop is kind of a phenomenon where as you start to warm patients, you potentially get worsening of their cardiac irritability. You can get worsening of their neurologic status, because a lot of these, basically the responsive mechanism to hypothermia is to shunt blood to the core to provide heat and oxygen to your central organs. We lose a lot of heat from the extremities, so that's why we physiologically do that. But as you start warming the body from the core, you can potentially get this cold, stagnant blood from the extremities, which can be cold, can be more acidotic because it has not been circulating as well, and has lower levels of oxygen, high levels of carbon dioxide. And so that can potentially make things worse. Vital signs can be tough. So this is something where you want to actually feel for carotid or femoral pulse for the recommendation is at least for a minute, because these patients can actually look like they're completely dead, these profound severe hypothermic patients. And they may actually have a pulse, but it may just be that their pulse is essentially 1 or 2. And as we talked about with the neuroprotective effects of hypothermia, that can still result in a good outcome. Rescue collapse. So this is something that people that have avalanche terrain in their regions, this is something to keep in mind. There is this phenomenon where if you take somebody that has been extremely cold, and it doesn't really matter their position, but a buried avalanche victim or somebody in submerged underwater, and you take them out, and then they suddenly go to a vertical position, this can actually cause it's basically a sudden decrease in preload, which is return of blood to the heart, and can cause really low blood pressure, which can precipitate a sudden cardiac arrest. And then obviously like arrhythmia, we talked about that the heart becomes very irritable. And so this is just to reinforce the term of circumrescue collapse, is that this was, and I can't remember what state this was in, but this was published in Wilderness Environmental Medicine of the WMS, and this was a 34-year-old skier who was buried in an avalanche for over 2 hours. When he was extricated, he was still alive, he was breathing and conscious. So you're like, oh, good job, we saved it. And these rescuers actually knew what to do, and they basically instructed him from standing up afterwards, after they dug him out. But I can't blame the victim, because I feel like any of us, if you're buried under under snow for 2 hours, conscious, without being able to move, you might have a little anxiety, and might feel like getting up after you got miraculously dug out. But unfortunately, this is that kind of circumrescue collapse where he stood up and went into VFib arrest. So he basically went into cardiac arrest, was in a ventricular fibrillation rhythm. I'm sure they don't give a temperature in the abstract here as to how cold he was. But I assume he was hypothermic after being buried for 2 hours. He went into a VFib arrest. They did everything they could for him, and he eventually died. And so that just kind of demonstrates how we need to be very careful of these patients, move them, with slow, methodical movements, and obviously prevent this like rapid change in horizontal to vertical positioning. This is also from the Wilderness Medicine paper. If you haven't seen it, we can have it sent out, but it's a really good read. I really like this infographic, and this is funded by the government in Canada. So this kind of talks about what we did already. So cold stress, not hypothermic. It's obviously like a little wheel here that is on the spectrum. So mild hypothermia, as we talked about, you kind of get conscious, you start shivering. I mean, you'll see people shivering, you'll see normal mental status, but some impaired mobility. And then as we get to moderate hypothermia, which was, we talked about, was kind of down to 90 degrees Fahrenheit, you'll start getting impaired mobility. Consciousness is still there, but then your mental status, so you can be conscious, but you cannot be alert. So not able to follow directions, potentially not shivering, which is our protective mechanism to produce heat. And then, as we get over here, this is what we're just talking about with those severely cold and unconscious patients. And so if you come up on scene and somebody is cold, unconscious, you don't really need a thermometer to determine what's going on. And then as we talked about before, taking 60 full seconds to check for breathing and a pulse, because they may have a pulse, it just may be very slow. Starting CPR is the ideal, is potentially ideal, but it depends on the rescuers and what resources we have. We'll talk about, so this is, if anyone hasn't done this, I encourage you to practice this with your units. This is a life-saving, essentially a very easy life-saving procedure that is bread and butter for mountain search and rescue. So I feel like probably everyone has experience with this, but if you're new to your unit, or you've never seen this, definitely look up how to do a hypothermia wrap. This is, like I said, it's just profoundly life-saving, because our patients are going to be, this is what keeps them from getting worse. And all it is essentially creating a kind of a vapor barrier, having an insulating layer, and then using sleeping bags, and then having a tarp on the outside that prevents the elements from getting in. There's ability, if your team has advanced EMS, like I said, like EMT or paramedic level or higher, we're looking at potentially, vital sign monitors that are wireless that you can potentially put in here, so you can potentially manage and continue to monitor continuously the patient's blood pressure, pulse, like oxygen level, things like that, as you're extricating the patient. Because obviously you don't want to continue to take their blood pressure every 10 minutes and have to take all this stuff off. But this is a very, very useful thing. This is what we use in Seattle. I have no connections to any of these companies, so I'm not endorsing one product over the other, but this is just something that we use, that we have on our rescue trucks to be able to deploy. So these are essentially, you open the package, it's like the hand warmers that you wear while skiing in your gloves, just big body, more core body size application of that. And these tend to work for 6 to 7 hours. So definitely recommend looking at these if or another brand if you are in an area where you see hypothermia on a somewhat regular basis. These are fairly cheap and can be very useful to throw in the hypo wrap. This is I thought this was a cool picture. This is up in, I believe, in Scotland, where it's very rainy and snowy and cold. And so this is what is known as a bothy bag, not to be misconstrued for a body bag. That has been, unfortunately, an issue on the radio sometimes, especially when we first started deploying these things, where you'd be like, "Hey, grab the bothy bag," and somebody's thinking you're asking for the body bag. So you could call it something else on the radio or whatever, but these things, there's several companies that make these, and if you're in, like I said, an area with snow, wind, or rain, these are indispensable. They're super small. Here's the video of a couple people that I believe have never actually set one of these up, that are deploying a 4-person bothy bag here in about 35 seconds.
1, go. Looking in there.
Obviously way too happy to be hypothermic, but you can see how quickly that is to deploy. I, again, have no financial stake in any of this stuff, but these things weigh, less than a couple pounds. And obviously they provide, there's no like poles or anything like that with a normal tent. They're held up by body weight. So there's 2 and 3 or 4 rescuers or bigger. So definitely something to look into. I think these work really well. They get people out of the cold and the elements while you're initially stabilizing them and then transitioning to the hypo wrap. So can be very useful. So again, coming back to this slide here, again, this is in that paper by the Wilderness Medical Society. I think this is just a good thing to kind of review. It's good to have potentially on your cards, or if you have anything on your phone, you can have this on your phone and just to review when you go out on scene. The big thing here that I like to point out is, the mild to moderate hypothermia is going to be fairly easy to recognize. When we get down to here to the severe, making the decision on whether to treat and transport or go down the pathway to this is unsalvageable is a much more difficult decision. Like I said, it depends on your resources. It depends on kind of circumstances. So if somebody, you can always see down here, lethal injury. So like somebody in an avalanche that has injuries, traumatic injuries incompatible with life, we would stop. If they are completely frozen to the point, like you see patients on, climbers on Everest where their chest wall is rigid. Those are patients that we're obviously not going to resuscitate. And then avalanche burial, greater than 35 minutes, but that includes and necessitates that they, when you dig them out, that their airway is completely packed with snow. There's obviously people that have been buried for longer than that that are able to be, like we said, with that gentleman, unfortunately, that passed away, that have an air pocket and can survive for hours. And then this is obviously a little difficult to read, but the take-home point for this is if there's no signs of life and you're going to decide to treat them, getting a core temperature would be ideal. It's not always possible. The gold standard is an esophageal temperature, which a lot of us are not going to be able to do in the field. A rectal temperature can be useful for a core temp. It's not as useful as we start to warm them, but for an initial temperature, it can be useful. So if you have that ability, I would recommend that. And then if they're below 30 degrees Celsius, which is that profound hypothermia, and you have the ability to have an AED or somebody with them, the recommendation is for only one shock, and then delay that until they're actually above 30 degrees. No drugs are recommended at that time. And then obviously if we're in the wilderness or in the backcountry, CPR for 3 hours is going to be difficult. Like I said, if you have a helicopter coming in and you have multiple resources, it may be possible, or if you're close to the trailhead, but doing intermittent CPR has been shown to potentially have a good outcome. So doing, there's no good studies on this, but doing a minute of CPR, taking a minute off, maybe 2 minutes off to move the patient, and then doing another minute potentially could help. And then the other one down here is potassium greater than 12 is terminate CPR. A lot of us are not going to have that in the field, but some may. I'm going to take a few minutes here just to go through a couple quick things with frostbite, because it kind of touches with cold injuries and hypothermia, but frostbite has basically a wide range of no frostbite, which is great, frost nip, to deep frostbite. The treatment for frostbite is essentially preventing things from getting worse. So we may see these with these injuries are going to be associated with hypothermic patients. If you pull somebody out from an avalanche, they're likely to have frostbite, or somebody up in the wilderness setting or in the mountain setting that's been out for several days. So surprisingly, when I was in residency in Phoenix, we actually got to treat a really bad frostbite, which was fairly eye-opening to me. And I learned a lot about frostbite that I actually had no idea about when I was a paramedic and working in search and rescue. So one of the things that can be beneficial, which if you have in your protocols and you have an extended field time, is ibuprofen. So this helps reduce inflammation in frostbite. It helps reduce the prostaglandins, which basically cause inflammation. And it's recommended a dose of 12 milligrams per kilogram up to basically a max dose of 2,400 milligrams per day, which for most adults is 3 over-the-counter tabs every 6 hours. Very simple intervention. It's a recommended intervention. So if you have the ability to do this, this would be worthwhile. Obviously, making the decision to one of the more difficult decisions is whether or not to rewarm somebody. So if you're going to make the decision to rewarm somebody in the field, you have to, and I can't stress this enough, you 100% have to make sure that there is 0% chance that they have that tissue refrozen, because they will have a worse outcome 100% if you're not able to keep them warm. So if you have the resources to get them out, then 100% you should rewarm it. Ideally, water should be 98 degrees to 102 degrees Fahrenheit to rewarm it. This is going to be severely painful. I'm sure there's a lot of people on here that ice climb or ski in the winter and have had the screaming barfies and know what that sensation feels like. I have never had bad frostbite, but I assume this is probably worse. So if you do plan to rewarm, if you have the ability to give pain medication with that, I would highly recommend that. But like I said, this should only be instituted if you have the ability to do it and keep it from refreezing. On the other hand, if we're not going to make the decision to actively rewarm, we want to passively keep these digits. It's usually going to be facial structures and extremities that are going to have frostbite, but we want to keep these things protected. And that's, like I said, just passive rewarming in the hypo wrap and using whatever resources we have to maintain heat and provide some active rewarming. Blisters on these are blisters that we don't want to pop. These are just some photos of potentially bad frostbite. The difference, this is something I learned when I was in residency. We did like I said, I was at Maricopa Medical Center in Phoenix. We had a regional burn center, and we did a 4-week-long burn rotation, which was one of the coolest experiences of my life. But one of the things I learned is, thermal burns tend to get debrided very quickly. They are very active in cutting the blisters off, looking at the underlying skin to see what that base layer looks like, because you can't tell how deep the thermal burn is until you actually debride the tissue. This is in basically the exact opposite of what you want to do in frostbite injuries, where debriding these wounds or popping the blisters can result in worse outcomes. The similarity in the two is that you can't actually tell how significant these wounds are until they evolve. So this obviously is not a superficial frostbite. There's blistering, there's hemorrhagic blistering, but this could be anywhere from partial thickness to that this is all frozen down to the bones, and this person's going to lose their legs. Obviously, this is another issue picture here of some fairly significant frostbite. And you can see there's darkening here with kind of blue-black discoloration of the thumb, which is likely actually like dead tissue. This patient's probably going to lose this. And this is just something I like to point out, and it depends on your area. And like I said, this is something I learned in residency that I did not know when I was doing mountain rescue. And this is knowing your resources and knowing potentially where you should transport these patients. So if you have somebody that has hands that look like this, and you're able to get them out of the wilderness, this is somebody that ideally should be sent by depending on where they are. I wouldn't say that they definitely need to go by air, but they need to go by expeditious methods of transport to a definitive facility. And what I mean by that, so that may be air if they're in the mountains, or if they're near the trailhead, they could go by ground, but they essentially need to go to a place that can provide definitive therapy. And what I mean by that is they need to go to ideally somewhere that's a burn center, an ABA burn center. This is, like I said, this is something I just learned during residency, but we had a patient that came in with severe frostbite to her feet after running. Unfortunately, she got attacked by somebody in her house and basically fled in northern Arizona out into the woods with no shoes on. And so she ended up getting flown down to our burn center with pretty severe frostbite. This video, or this image right here, is what's called an angiography. So it shows the blood vessels, and this could be the feet or the hands. So it shows the blood vessels. It's basically like a catheter is inserted into the artery in the upper extremity or groin, and you're able to shoot dye through that, which goes through an X-ray machine, and we're able to see blood flow. And you can see here that there's no blood flow to the blood flow becomes much less dense. And so this is what we see in frostbite, is you get these extremity injuries that don't have blood flow to them, and that's why a lot of this tissue ends up dying, and you lose digits, fingers and toes. So the reason I stress this is that if you get them to the right facility, and this usually has to take place within the first 24 hours, which is why I kind of stress the time sensitive nature of it. They can place, so either burn surgeons or, radiologists can place a catheter into the arteries, and we're able to deliver a medication, which we give for, acute stroke called TPA, which is basically dissolves clots. And this actually, and in this patient that I took care of, it was an N=1 anecdotal experience, but it is recommended that you will give TPA through a sheath. So it's not systemic. We're not giving it through an IV through the entire body, but we're delivering it in very specific areas in the body. So into the upper extremities or lower extremities. And this has been shown in the first 24 hours to provide a better outcome. So it's just something to keep in mind in these patients that may not have good blood flow. And in this case the patient that I took care of, she had perfusion, lack of blood flow deficits to her basically to her distal toes. And after 24 hours of the therapy, a repeat angiogram, which is what we're seeing here, basically showed resolution of that. She ended up doing really well. That's not going to always be the case, but it's something to keep in mind in these patients with really bad frostbite that may end up doing okay. And with that, I think we're at almost at an hour. So I'm just going to there's two case examples here. This is a patient from 2020 that Seattle Mountain Rescue, I believe, and Mount Rainier and Mount Hood were probably involved with. So this is a patient that was, he was basically profoundly hypothermia. I think it was a snowshoer that got basically disconnected with his buddies. And then he fell. I believe he was in a creek, potentially in a creek bed, but he was found prior to having a cardiac arrest, and I believe he was being hoisted into it was either I believe it was a Navy helicopter, and while he was being hoisted in the helicopter, he eventually he went into a cardiac arrest, I believe, getting into the helicopter, which is kind of what I emphasized before with big movements, vibrations, things like that. These profoundly hypothermic patients are going to be at the highest risk for having those ventricular and cardiac arrhythmias. But in this case, they're already in the helicopter. They started CPR. They took him to Harborview, and which is the trauma and burn center in Seattle. And you can see here, this is him after he was awake and rewarms. He got put on ECMO, which is basically cardiopulmonary bypass, where they put a catheter into the neck and into the groin and are able to basically bypass your heart and provide circulation for the body and the brain. And this guy had a complete recovery. And again, it's just something to keep in mind, that some of these things and some of these very sick patients will have a good outcome. This was another one in Europe, that was a 29-year-old who was completely buried. He was buried for 100 minutes at 10 feet after an avalanche. He was unconscious but breathing with a core temperature of 71.6 degrees. He was intubated, ventilated, and obviously they had, this was in Europe, where they have rescue helicopters almost in every village. So they tend to have higher, advanced life support in the field, including physicians. But they were able to intubate him. I believe they defibrillated him once, but it didn't work. His labs looked okay, and they took him to the closest facility that had ECMO, which is what the last patient had, was placed on as well. And this patient came, basically was able to be rewarmed slowly and had a complete neurologic recovery. So just something to keep in mind, that these may be few and far between, but that decision to go ahead with resuscitating versus not is tough, because some of these patients may look like they're completely dead, and that one case will be the one that you'll remember for your entire career. But obviously you need to take care of yourself first and make sure you have the appropriate resources. And a lot of that just goes into planning with your team and knowing where these patients are going to go and how to treat them. And that's pretty much all I got. That was my first dog, Sienna. I like to put her up there because she was the love of my life. And then I appreciate this. This is in Phoenix. They prevent. They will actually cite you in the summer if you take your dog hiking and it's too hot. So April, October, you can't take your dog out if it's more than 90 degrees, and they will give you tickets, which is probably I would agree with. Does anyone have any questions?
Yeah, we do have one question here, Brian. Having not seen frostbite in person, would the swelling and blisters be present in the field prior to rewarming?
So typically not. Like if you come on somebody that that's acutely frostbitten, the chances that those blisters are going to be there are probably that's not going to be the case. It's going to be, the tissue is going to be frozen essentially. So that tends to only happen when you start rewarming them.
Okay, and then the next question, any suggestions for preventing after drop in the field while actively warming?
I don't have any suggestions for that. It's just something to keep in mind. And this is going to be in those, it's just something to keep in mind for, and this is, like I said, it's going to be the sicker patients that you're going to be taking care of. So those patients that their temperatures are under 90 degrees, potentially even cooler. And it's just something to keep in mind. So if they're improving and then they start getting worse, I've never seen this personally. It's documented in the literature, and it's a known phenomenon, but it may not happen every single time. Like in everything in medicine, we have lots of things that we think make sense, but it's not going to be the case for every single patient.
Okay. As of today, what other invasive method besides ECMO do you know for rewarming?
Yeah, so I think the best is ECMO is kind of the gold standard. You can, I actually have to look this up real quick. I believe ECMO rates for rewarming are 1 to 2 Celsius per hour. So that's, let me look this up because I want to make sure I have this accurate. So there's the stuff we're going to do in the field is obviously going to be conductive, and using like hot water bottles, things like that, external heat packs. Yeah, and I'll have to get back to you because I don't want to waste people's time. But the other option, which I believe is 1 degree Celsius per hour, is, and this doesn't have to be at a place with ECMO, is you can use dialysis machines, and essentially any emergency department, any hospital that has nephrology, which is much more common than having ECMO. ECMO requires much more specialty care with cardiothoracic surgery and things like that. So it's relegated to a smaller percentage of bigger cities. Most smaller cities will have the ability to do dialysis, and that, putting a dialysis catheter in, we're not actually dialyzing the blood to like remove toxins, but you can actually use the machine to warm the blood. So that, I believe that can be at 1 degree per hour. So that's actually, pretty quick. Other than that, there's anecdotal stuff of doing things like like whole bladder irrigation. You can put like a fully catheter in and irrigate the bladder with warm water. You can put chest tubes in. I know this has been done in the past. I don't think anyone really does that anymore, but putting chest tubes into the, like multiple chest tubes into the, into the thoracic cavity and doing, basically like irrigating the chest cavity with warm water. There are some devices that are able to put in through the vasculature, like central lines that go into the veins in the neck or the groin that have heating elements or cooling elements, but I don't believe they're as effective as ECMO or dialysis. And ideally, these patients that are that sick that need that invasive rewarming should ideally be transported initially to those centers, because they're going to have other, other modalities that these patients are going to need to get better.
Okay. If you're in the field with no temp probe, is mental status the best way to assess degree of hypothermia after ruling out head injury, drugs, alcohol, etc.?
Yeah, no, that's tough because there's going to be a lot of things you're not going to fully be able to rule out in the field, like, head injury. You can still have a head injury without evidence of trauma, external trauma or obvious trauma. So it's just something that I don't think they're going to be able to say 100% that that the degree of hypothermia just solely based on their mental status, but I think you just have to take everything in context. So you may not be able to rule out a lot of that stuff, but if somebody is profoundly cold, feels cold, is altered, you should just assume that they have a severe hypothermia and intervene based on those circumstances, despite whatever else may be going on.
Okay, can you give an example of how you have dealt with severe or moderate hypothermia in terms of triage?
Can you elaborate on what you're, in terms of triage, and asking on that? I just wanted to make sure I answered that question appropriately, Emily.
And Emily, you can come off mute if that's easier. Where does severe hypo come into play in a triage situation?
Gotcha. So are you thinking if there's like multiple patients or like an avalanche or something with like multiple buried patients? Gotcha. Okay. Yeah, that's I think I mean I don't have this may vary, but I don't necessarily know if I have the right answer. I think anyone with mild to moderate hypothermia, if anyone's familiar with like START triage, which is what you use in the urban setting, where you triage somebody as green, yellow, or red, or black, where green people are people that can walk. And, basically when you show up on a mass casualty, you say, hey, anyone that can fall, anyone that can walk, come over here. And you basically self-triage everyone that is not sick and can be delayed. So I think I would do that same thing in the wilderness. Anyone that can follow directions, has the ability to know what I'm saying, can follow directions and can move, despite whatever temperature, I don't even care what temperature they are, they can be delayed. They are not sick. And if you have multiple patients to take care of, I would get them, if you're in the elements, obviously giving the resources to get them out of the elements and the weather to prevent them from getting worse, but not necessarily devoting your direct medical attention or evacuation resources to them initially. So, and then I feel like I would triage like the moderate hypothermia. So people that are awake, but not, maybe able to walk, to more of the yellow or red, where they need to get treated quickly, but not necessarily right now. The profound hypothermia, and this is totally going to be a judgment call. If you have 6 or 7 patients on scene, and you have that one that maybe you feel pulse every like 1 minute, once a minute, thing like that, which I don't know if that ever happened, but that patient, if you have several of those like moderate to severe with bad injuries, I think that's like I said, it's kind of a judgment call, but in that setting, I think I would probably somebody that's just like almost looks dead and essentially is dead, I would probably err on the side of calling that like a black patient that, you know, if we had the resources and that was the only patient, we may be able to save, but in the setting of a more mass casualty, unfortunately, we try to do the best for the most good, and that's somebody that I may not devote resources to.
Thank you. We have another question here. This one looks like it's a two-parter. Could you speak about the likelihood of detecting a pulse during the 1 minute duration, given the environment and even technical terrain condition often encountered in mountain rescue? And looking at long duration CPR, are there many responding units with a Lucas device?
Yeah, so like I said, I personally have not come on an avalanche victim where I've had that experience personally. So if anyone has on this talk, feel free to speak up. But I feel like taking 60 seconds to feel for a pulse is going to be tough. Even I'm working on a project right now with the fire department I work with, using ultrasound to actually detect a pulse. And this is like in the field and in the urban setting, because we know that detecting pulses as rescuers can be very difficult in somebody that is in cardiac arrest. So I think it's very difficult. I think it's something we should probably do because it's the recommended duration, but obviously that depends on the weather. Like if it's sleeting or you're in a blizzard, you're not going to take your hand out for a minute because you may get frostbite yourself. So I think it depends on the situation. And then in terms of Lucas devices, I don't know of any mountain rescue organizations that are carrying the Lucas device. I doubt there are any. If anyone has any information on the contradictory to that, feel free to speak up. Those are going to be devices that would likely be brought in by your air medical resources, or when you get the patient to the trailhead with ground EMS. So that's ideally that would be something you could do, because that would, if you're going to do continuous CPR for 3 and 4 hours coming out of the mountains, that would be ideal in terms of rescue fatigue. But yeah, those devices I don't think are necessarily rated to work for hours in the cold, and they are heavy, so it's not something that I think is, and they're expensive, so I don't think it's something that we would need very often, because this is kind of that 1 or 2 event maybe per mountain rescue organization in a couple years, if that. So I don't think having that resource would be potentially beneficial.
Yeah, Brian, this is Josh. I asked that question. Can I ask a follow-up, maybe clarifying on some of that?
Yeah.
So I guess what I'm hearing is, new recommendations of the 1 minute pulse check, which I agree, I think from experience seems unlikely, and it seems fraught with the possibility of not detecting said pulse. And so then the next or the next decision or sort of move in that is supposed to be long-term or long duration CPR, which I'm suggesting that because most rescue units aren't carrying it, we need to wait at least until we get to a ground-based ambulance, or possibly even, I don't know, there are a few, Life Flight or other sort of air ambulance services that might be carrying Lucas devices, but it's still that duration in between establishing when we think they have a pulse or not, which I think we might be not great at.
Yeah.
And then getting to that Lucas, that's the thing that I'm wondering. So in that, given the question that often comes up from both team members or even, people being trained, is should they start CPR? Right. And if we know that because of the neurological sort of shunting, we're at a place where, whatever we used to call it, the metabolic icebox, what have you, is that a time in which we're worried about creating an issue? Or should we just be convincing people, because the current recommendations are start long duration CPR?
Yeah,
Do you have a thoughts on that? Like when the rubber meets the road, what you would
yeah,
do?
I mean, I think the answer is it just depends. It's not a great answer, it's a cop out, but I think it depends on your your organization, and like I said, it depends on the variables. So like, can you get a helicopter there reliably that can in the mountain scenario that can potentially like hoist or short haul the patient and bring the resources in a short amount of time? If that's the case, then I would say we probably should be, doing those interventions to give that patient the best outcome or best potential outcome. But if you're looking at a 3-hour, slog back to the road with like low angle rescue or like in a toboggan, things like that, I think it's something to talk about beforehand, but I just don't see that being very feasible and resulting in a good outcome. I think that kind of goes into the triage scenarios with a mass, and then we talk about this, a mass casualty doesn't need to be multiple patients, like 10 patients for, it's essentially any situation that overwhelms the resources that we're able to deliver. And so thinking of that in the wilderness, like if we only have, say you only get 2 or 3 rescuers on a hasty team to a patient initially, and it's going to be hours before we can get anything else. And it's that kind of situation that may be somebody that we just unfortunately can't devote those resources to in that particular day.
Great, thank you.
And then Brian, one more question, and then we won't take up any more of your time. Thank you very much. So the last question is, if it's difficult to check for pulse, can you check for perfusion, even though it may not always be indicative of lack of pulse?
Yeah, I think that'd be tough, because perfusion is going to be the best way to check for perfusion in somebody that's good perfusion, at least to the brain, and in terms of somebody that it doesn't have to be hypothermia in terms of any patient, is to basically like ask them a question and say, hey, how are you? And if they can talk to you, you have good perfusion to the brain. But in these patients that are going to be hypothermic, that shunting to the core, you're not going to feel anything in their, I know somebody, CVT just put start triage uses cap refill, which is true. They use cap refill and radio pulse. But in these patients, your cap refill in the extremities is not going to be non-existent, because there's essentially no, there's no blood flow. It's just stagnant blood that's cooled. So in this patient, the best, like in the hypothermic patient, essentially the only way to check for perfusion, I think, is to check for, other than putting in like invasive measuring lines, which we're obviously not going to do in the field, is to check for a central pulse, either femoral or carotid.
Great. Thank you so much for your time, Brian.
Absolutely. Thank you for having me.
And that concludes our talk this evening. Thank you, everybody, for your time. Have a good evening.